Our speaker for today, Dr. Przemysław Holko. Przemek serves as an assistant professor at the Department of Nutrition and Drug Research, Institute of Public Health, Faculty of Health Sciences, Jagiellonian University Medical College in Kraków, Poland. He received his PhD in public health in 2022 from the Jagiellonian University. He is an author or co-author of more than 40 original peer-reviewed publications in public health. His research interests include economic evaluations of medical technologies, real-world data, analyzes statistical modeling of observational studies, indirect costs of disease, and pharmacoepidemiology. Okay, so Przemek, you can start your presentation. The floor is yours.
Okay, thank you. We'll try to share the screen.
Yes, we can see the presentation.
Yeah, perfect. Full screen. Very good.
Okay,
Okay,
you can proceed.
Okay, so thank you for joining this another webinar, and thank you for having me. I will talk about decision analysis and modeling in economic evaluation of medical technologies. This is so-called pharmacoeconomic analysis. This is, of course, a part of health economics. In this introductory session, we will cover decision analysis, including how to create the basic decision tree to estimate the expected costs, the expected outcomes. I will also introduce Markov models and finish with the very quick, very short overview of partitioned survival models. There are many tools for model-based economic evaluation of medical technologies. These include decision trees, state transition Markov models, partitioned survival models, and discrete event simulations. Additionally, some hybrid approaches, such as combining Markov model with decision tree, can be also used. We will focus mainly on the main model, most frequently used models in health economics, Markov models and partitioned survival models. But understanding the decision tree will help us to learn more about Markov models because Markov models can often be seen as more advanced, more complicated, more complex decision tree with looping, with some returning to the previous decisions aspects. So let us start with the decision tree. Imagine you are in line to buy a lottery ticket, deciding whether to wait in line or to wait in line and buy the ticket, or just leave the line and go home. Buying a ticket gives you a chance to win the lottery prize, but you risk losing your money and time spending waiting for the ticket. If you want to make a rational decision, you need to collect some additional data, need some additional information. First, we need to define our decision problem. In our scenario, we can buy or not buy the ticket. So those are our alternatives. We know that the ticket will cost us 10 euros, for example, and that each ticket can win 100 euros. This is important to note that there are multiple tickets that are winning. And to analyze the decision, we need, unfortunately, some probabilities. We need to know the chance of winning the lottery. We can get it from the lottery organizer or from some historical data. Suppose before us in the line there were 20 people who bought the tickets, and 3 of them won the lottery, which means that 17% lost the lottery. From this, we can calculate that probably the future probability of winning the lottery is around 15%. So 3 people divided by the number of participants in the lottery. Now we can build a decision tree to decide what choice is best for our money. A decision tree helps estimate expected outcomes before making a decision. It is done by looking at possible future results scientifically. For our decision to buy or not to buy the ticket, we can build a decision tree for our expenses and our incomes. So for everything that goes in or goes out from our wallets. This is called in health economics, this is called an economic perspective, which basically addresses the questions who pays for stuff. In our example, we are the payer for the ticket. We can win the lottery prize or we can lose the money that we invested in the lottery ticket. We start building the decision tree by stating our current position and listing the exclusive choices, buy or not to buy the ticket. So we are here, and we are here, and our choice is to wait in line and buy a ticket, or to leave the line and go home, do nothing. Exactly with this regard. So next we add the consequences of each choice, so winning or losing if we buy the ticket, and no change if we don't buy the ticket. Then we add probabilities to the graphs in place, so-called stochastic nodes. We have only one stochastic node. We are adding the probability of winning the lottery and probability of losing the lottery to the graph. So the probability of winning is 15%, and the probability of losing the lottery is so-called complementary probability is 85%. For the do-nothing strategy, nothing changes, so we put 100% here. Next, we add the cost of each event or each state to the graph. We have only two cost categories: cost of the ticket and the lottery price. The ticket is 10 euros and the winning adds 100 euros to our wallet. So the price is shown as a negative cost to indicate that those money are gained. In other words, the price has a different direction flow than the cost of the ticket. The price is going in our wallets, the cost of the ticket going out from our wallets. And next we calculate the so-called branch cost. The branch in a decision tree is mutually exclusive path from the beginning to the end of the tree. Here is highlighted one path which is ending with the winning the lottery. To calculate the branch cost, we just added all costs encountered during the path. So the cost of the first branch is minus 90 euros. In the second branch, the losing branch, we have only one cost. This is the branch where we pay for the ticket and we win nothing. So the branch cost is just the 10 euros spent on the ticket. And for the do nothing choice, there are no costs, so the branch cost will be 0. So with this fully set up tree, we can now calculate the so-called expected outcomes, expected cost, and guide our decision. So after calculating the branch cost, we can calculate the total cost for each strategy, for each alternative. We calculate the expected cost by multiplying each branch cost by its probability and summing this up. So we have the winning branch occurring with the probability of 15% and the losing branch occurring with the probability of 85%. So the weighted expected total cost of to buy ticket strategy is minus 5 euro. The do nothing strategy will give us 0 euros and takes from us 0 euros. So the total cost, the expected cost for this strategy will be 0. After those calculations, we create a table with the decision tree results. we compare those total expected cost of each strategy, and based off the so-called incremental cost, we can choose the alternative which is the best for our money. So we compare -€5 versus €0. But it's good to remember that the -€5 is not money in our pocket for every ticket we bought. But it's indicating that if we are willing to buy, for example, 100 tickets, that we will have additional €5 on average per ticket in our wallet when we do this. And by comparing those total expected costs, we decide which is the best alternative for us. So in our case, choosing the buy ticket strategy over the do nothing strategy, we are expected to earn €5 on average. So in other words, doing lottery multiple times, we earn around €5 per ticket. So in our case, the best decision for our finances is to buy the ticket. So generally, this is the process of building and interpreting the decision tree. And in short, the decision tree are simple one-way diagrams showing sequences of decisions, sequences of events, usually without loops or going back to the same decision, taking over and over again. And in health economics, decision trees can analyze costs and also health benefits, such as life years gained, quality adjusted life years, days without symptoms, numbers of events avoided, and so on. So for our decision tree, where we check the money that we can lose or can win in the lottery, we can, for example, use some kind of measure of satisfaction or happiness to guide the decision we will making. So in such case, we will be using the cost outcomes, cost total expected cost outcomes, and other measures of happiness or satisfaction with the lottery. But this was very simple example. This is the decision tree are used mainly for the very simple cases. For more complex decision, we use Markov models, which track transition between health states over time. For example, let us consider two strategies: vaccination against the common cold versus no vaccination. A decision tree would get complicated because a person can get sick multiple times during the study period. This would require looping back to the earlier points in the decision, repeating over and over the same checking if patient is healthy or gets sick. So basically, where there is a timeline, where there is a looping in the decision tree, we used a Markov models. And the model can be shown as a very complex tree with as it here with the timeline, but also can be represented as the diagram, where the shapes are the states and the arrows indicating allowed transition between states. Usually, when we conduct modeling, we run separate Markov models for each strategy. So in our case, this will be one model for vaccination strategy and the other model for no vaccination strategy. We start with a group of people and simulate what happens to them during each time cycle. So we start with a group of people in one state and try to calculate what happens to them in the next cycle, in the next month, for example. So, for example, here, one patient after 1 month of observation gets sick, the other do not change their state. In the next cycle, one additional patient gets sick, others do not change their states, and so on and so on. Markov models have one important feature called memoryless, which means that the chance of moving to the next state depends only on the current state, not how the patients got to the current state. In fact, in statistical analysis, when someone is referring to the Markov feature, it always will be the memoryless feature. And to conduct Markov modeling, we of course need some probabilities. Those probabilities are obtained from the literature, from the clinical studies. You can use, for example, some historical data. For this model, with two states only, we need two probabilities, a P1 probability and P2 probability. And there are two types of Markov models. There is a standard Markov model where P1 and P2 are constant, so they are not changing every cycle. And the semi-Markov models where the P or P2 are changing during the time horizon. For our example, the P1, for example, can be lower at the start of the modeling when people are younger, and will be higher at the end of time horizon when people are older and more likely to get common cold. To run a Markov model, we often use a matrix of transition probabilities, where each cell represents the probability of moving from one state to another. Each rows, of course, sum up to 100%. So this is the very good feature. And with matrix of transition probabilities, we can populate the full model. We assume some number of patients at the start of the modeling and define the entering state. Here, we have 1,000 people in the healthy state at the start of the modeling. The start of the modeling is often referred as the cycle 0. Then we calculate how many people move to each stage during each cycle using the transition probabilities. We can use advanced math, some matrix algebra, but it's easier to use to look at each column of matrix of transition probabilities and use basic maths, multiplication and addition. Basically use those formulas to populate the model. And similar formulas can be used for subsequent cycles, and repeating this calculation over and over cycles gives us the fully populated Markov model, as in this example. And please note that at each cycle, the total number of people in all states adds up to the original group size. We can also show the Markov model as the flow diagram with arrows showing how many people leave states going to the other states, but it's more complex, it requires more time and more space. In fact, this diagram alone contains all necessary information for conducting all modeling with Markov model. And the last type of model I would like to present is the partitioned survival model. Instead of tracking transition, this model looks at how many people are in each state at a given time point. It's often used in cancer studies to compare overall survival, which is the number of patients alive, and progression-free survival, which is the number of patients alive without disease worsening, disease progressed. And we can use those endpoints, overall survival and progression-free survival, in the model to obtain the percentage of patients in each state. For example, here we have a 10% of patients in the before progression, in the progression-free state, around 60% of patients in the progression state, so after progression, and around 30% of patients in the death state. So this means that to this point, around 30% of patients died. So these were the main models used in health economics. And it is good to know that in Markov models and partitioned survival models, after calculation, the cost and health benefits are assigned to each state. So we calculate this table with Markov models and partitioned survival models, the occupancy of each state in a given cycle. And then we calculate expected cost and benefits by multiplying the percentage of people in each stage by the cost or health benefits assigned to the states. After this, we sum those numbers, those results over all cycles and compare between alternatives, comparing between strategies, usually treatment. And my final remark is that the models are just simplified representation of reality. We include only aspects relevant to the disease or medical technology, not everything. For example, if in the assessment of vaccination strategy, we used only occurrence of common cold, for example, or occurrence of the disease, but not, for example, occurrence of cancers if it's not related to the vaccination or to the group of people that we included in the model. So I think that's all from my part. Thank you very much. I show you some simplified version of the Markov modeling. Here you can see the more advanced, more complex models that was used for the assessment of biological treatment of Crohn's disease. So it's more complicated, very much advanced math tools needed to use to calculate this, but even the most advanced models follow the rules that I showed you earlier. So thank you very much for your attention.
Okay, thank you, Przemek, for the description. Clearly, these sophisticated issues. I hope the presented issues are now a piece of cake for the audience. I believe, I hope so. But okay, let's open Q&A session. Please ask any questions or just thoughts in relation to the presentation.
I can start maybe. What I understand the difference between the Markov model as compared with the other model you present after that is it looks like the Markov model is more dynamic because you can change from one state to the other. Is it correct to say that it is more dynamic?
Yes, it's more. You can follow you can track the patient's history in the Markov model, but you cannot do this in the partitioned survival models. Partitioned survival models is some simplification, simplified version of the modeling, but is widely used in the oncology, because it can use direct results from the clinical studies. So the overall survival results, progression-free survival results are directly taken from the clinical trial. So it's easier to conduct this, but it has much more limitation than the Markov model itself. Yeah, you're right. Thanks.
So thank you for this, because you could speak in a very plain language, something that is not very easy to understand the Markov models who have been listening about Markov model, but the way you present it today is really nice. So and it's a good introduction on what it is, and it can be very complex, and it can be also applied to a biological phenomenon. So we have been discussing with the clinician, and James is here. So we know that some patients are immunized to the drug, but there are some transient immunogenicity. So we can maybe model some patient being developing anti-drug antibody and then come back to the normal without ADA, and it's something that maybe we can apply to a biological phenomenon. Yeah, it opens my eyes on the complexity of this. And is there any other question? We are about to close this webinar, and after that we're going to have a core group, a short meeting So unless someone would like to add something, I think we can adjourn and stop the recording. But before that, we can announce the next one, the next webinar.
Yeah, of course. Next webinar is scheduled for 9th of September this year from 5 to 5:30 p.m. set. And a speaker will be Konstantin Tashkov from Medical University of Sofia, Bulgaria. And the title of the webinar would be Economic Analysis Models. So please register for the next webinar. And thank you for attending and participating today event. And see you at the next webinar next month.
And the others can keep for the core group can stay online for the discussion. And I'm stopping the recording. Where is that? Where is the record? Okay, I can